Okay, so we're going to look at some areas. We talk about them small, then we look at their related questions, some of them, and how best we can deal with them. First of all, let us talk about celiac disease. We're going to look at these 5 things because they are they are the things on this page. So we're going to look at them briefly. Then on the next page, we're going to look at some few questions on them, applying all that we've gone through, the tips that we learned. I'm not just jumping onto them because maybe some of us might have forgotten about this. Some pertinent areas on these topics. So we're just going to go through some of them briefly. Then we jump onto the questions, applying all that we've learned about the strategies. Remember, we said the master of it all is your content. What I mean by your content is the knowledge about what is being asked. If you don't have any knowledge about that, your strategies will not go anywhere, okay? And it won't help you. So first of all, celiac disease. When you hear of celiac disease, what comes into your mind? Sometimes you see coeliac disease. They are the same thing. I'll not even ask. Okay, they're the same thing. So celiac or coeliac disease. We have some other names too that sometimes they are used instead of the celiac disease. You have something like sprue. Okay, SP. I'm trying to see if I can write something. So we have SPRUE. Okay. And you see something like sprue. Sometimes they even add celiac sprue. Okay. Or gluten sensitive enteropathy. Gluten sensitive enteropathy. So when you hear of all these things, if you don't see celiac disease and you hear something like gluten sensitive enteropathy, in cases of case study questions and all of that, if you see those things, don't think plenty or don't think it's something out of context that you've not even heard of before. Okay. So those are some of the ways you can see in place of them. All right. What happens in someone with celiac disease? Remember, it's an autoimmune disease. Okay. Whereby people get, or those who have this condition, they get chronic intestinal inflammation, okay, in different varieties, or let me say in different degrees, depending on what is happening, okay, or the severity of the whole condition. And it's all because of the protein called gluten, okay. It's all because of the protein called gluten. So when you hear of someone or a question talking about gluten intolerance or this thing, it's all about this celiac disease we are talking about. So we have a protein called gluten, and these people tend to react. Okay, it is an intestinal inflammatory condition, and of course, an autoimmune disease. They tend to get lots of symptoms like abdominal pain, cramping. They get weight loss, failure to thrive because of periodic inflammation they get upon taking gluten-containing foods. Okay. They tend to even get iron deficiency and the rest. Everything they take in containing this gluten, they tend to have all of these symptoms we've mentioned. And they end up having this condition, failure to thrive. Okay. Remember, they can also get abdominal distension. They have steatorrhea. the nature of their stool. Okay, that is the word used to describe it. Steatorrhea. It's a very foul smelling stool. Okay, it's a very foul smelling stool. Uh, we have to take note of that. And let's note that, because it's an autoimmune disease, it doesn't mean it happens to only children. It can be present in both children and adults too. Okay. So let us take notes. And it depends on, you see, where it affects in the intestine. It depends on which one, okay, or which parts that is being affected. But most of the time, the proximal ones, those closer to the stomach, okay, those ones get affected more. And in severe forms of this celiac disease, you can get anemia, megaloblastic anemia in this case. You can get infertility. So if you think nothing is linked to infertility, nothing about celiac disease is linked to infertility. This is, this is just presented to you that infertility can also happen in severe forms of celiac disease. You can have amenorrhea, osteoporosis, and all of that. Okay. Yes. So iron deficiency, anemia, and all of that. You can get them if you have severe forms of the celiac disease. We're just trying to brainstorm. Okay. We just remind ourselves of some of the things that happen when when you have celiac disease, then we can try and relate it to questions, how to deal with questions concerning that. So if you have any additional information to add, you can add. Okay. We have to look at their food. It's very, very important. So let me touch on the foods. Then if anyone has any other information to add up, you can add up. We are all brainstorming about these conditions here. Then we apply them to our strategies and see. Remember, celiac disease, you don't take any food that contains gluten. Okay. You don't take any food that contains gluten. So let us look at some of the foods that may contain gluten. And of course, they are not supposed to take. They're not supposed to take ice cream because it contains gluten. Non-dairy creamer, yogurt with fruits, cocoa mix, tea, yes, tea, okay. Then canned soup or any soup that has been mixed, like soup mixes and all of that. They're not supposed to take. They are not supposed to take instant coffees, hot dogs, and lunch meat. Okay, ketchup, they don't take. Tomato sauce, peanut butter. Yes, they are not supposed to take all of these things because they contain gluten. Okay. And over here on the slide, we have give gluten-free diet. So no bread and no vanilla. So the ice cream that we're talking about, sometimes it can be given in that way. Okay. But they can take corn and rice. Okay. They can take corn and rice. Any other condition? Sorry, any other thing someone wants to add? I'm the only one talking here now. But I hope it's nothing new to us. Most of us, we've already gone through and we know, right? Okay.
Saima,
Yes, sister.
please talk about the brow, the belly, rye, oats, and feet. What is it associated with? Is it celiac disease?
Is that what?
The brow,
Brow. Okay, yeah.
belly. Feeling.
Yeah. So brow is an abbreviation. Let me write it here. Bali. Where's my pen card? Thank you for even bringing that one up. So we have the brow diet. So we have Bali, Barley. We have the rye, right? This one is who is which one? Oats. Is it oats?
Yes, oats,
Yes, oats,
And this one is what?
wheat, wheat.
feet,
Wheat.
feet.
Okay. So we have this brow diet. That's people with celiac disease. Thank you for bringing this one up. Okay. It is not safe for people with celiac disease because they contain the protein gluten. Thank you very much. Okay, so people with celiac disease or celiac sprue, you don't take anything containing barley, rye, oats, wheat. They can take rice, they can take corn. So let us take note of the differences. Thank you. Thank you very much. All right. Any other thing to say about them? Their characteristics too, we've mentioned it. Take notes very, very, very well. All right. Any other thing to add up? All right. I think we should now move on to, we are just doing some recap, okay? We are not treating them into details, we're just doing some recap on these areas. Anything you remember, you can add up so that we use them to answer our questions. I think we've said enough about celiac disease. Now let us talk about the second one, Viagra. What is another name for Viagra? Another name for it.
Sidel,
That's where they sildenafil.
Sildenafil.
Okay. Sildenafil. Unclear on this. So you've talked about this in brief. Now let's go to this one. So sildenafil. And when we talk about sildenafil, you know, it is for what we know, for what is commonly used for. We know that it is used to treat people with erectile dysfunction. Okay. The class that it falls in is phosphodie. It's a type of phosphodiester. Okay. The word is too big to pronounce. Phosphodiester. Okay. Phosphodiester inhibitor. Yeah. Phosphodiester inhibitor. Forgive me about the pronunciation. Okay. Uh-huh. So it is used to treat erectile dysfunction, but I think this is the commonest type or form of usage that most of us are aware of. We have another condition that you can use this sildenafil to treat. Who can mention that? Apart from erectile dysfunction, you can use it to treat some other thing.
Is it pulmonary arterial hypertension?
Pulmonary hypertension. Good, good. So Those of us who haven't seen it before, sildenafil can also be used to treat pulmonary hypertension. So when you see pulmonary hypertension questions that have this sildenafil all around it, it is one of the drugs that can be used to treat. Okay. All that you have to know, the mechanism of action, the Nclex wouldn't ask you too much, but even if at worst, what it could ask you is what it does to vessels. Okay. And according to its action, its mechanism of action, at the end of the day, it will end up causing vasodilation. Okay, it will end up causing vasodilation. They will dilate your vessels so that you can have flow of blood through your vessels at ease. So let us take notes. Okay, phosphodiesterase inhibitor. All right. We have other concerns you can say about this Viagra thing. So look at, just have it in mind, or just consider this. A drug that has vasodilation property. If someone is taking a particular drug already, let's say someone who is on nifedipine, okay, someone who is on nifedipine because of maybe a long-standing hypertension or something like that. If this person wants to use this Viagra, that is where our issue, or let's say that's where our issues will come in. Okay, calcium channel blockers, they end up also opening up vessels, they relax vessels. Okay. When you take Viagra, also cause vasodilation. So when you know the action, and if you know the action, the mechanism of action of the drug, any question being asked about the drug in relation to some other type of drug, if only you know their mechanism of actions, you can actually tell if it is safe to take both of them together or around the same time. Okay. So this is just some of the things that we're talking about. And forget about the drugs, even for now. Consider someone with a condition that leaves out, or let's say, consider someone with a condition that ends up with a person having already dilated vessels, okay, causing issues. What do you think could happen? When your vessels are dilated, the cardiac output or your blood flow through those vessels to end organs. What I mean by end organs is that, consider, let me give you a scenario here. Let's say there's a vessel. Actually, it's supposed to be this size, but because of an issue, it has been dilated already to this size. The blood that this size should contain to be able to perfuse an end organ. Let's say this is a particular organ that this vessel is perfusing. So per the weight, or let's say the lumen here, the size of the lumen here, you're going to have effective blood supply to these vital organs than considering a dilated one with the same amount of blood flowing through. Okay, that is why when you have these vasodilation properties, like, at worst, hypotension and the rest. Hypotension can come from different sources, but let's say if you have dilated vessels like this, it will be difficult for the same amount of blood to perfuse end organs, okay, because of the resistance that's, or let's say the push that it should get from its normal lumen. Okay, it is like trying to I don't know if you understand what I'm trying to say here. If you have a larger lumen, blood supply to vital organs will not be as fast and efficient as a normal vessel. Okay. That's why when someone even has hypotension, we try to give drugs that can constrict the vessels a lot so that you can push blood, which is in those vessels, to vital organs for them to be well nourished. So when someone is taking sildenafil, it means we we want to dilate the vessels. Okay, the pressure in there is high. So let's say in cases of this pulmonary hypertension we are talking about, the pressure within the pulmonary vessels are high. We want to give this drug so that we can relax the pulmonary vessels a bit for blood to flow through. So when you take sildenafil to treat sexual dysfunction, you want to relax and dilate the vessels a bit, okay, for blood to be able to fill your penis, okay, so that you can get your erection and of course use it as you want to use. So that's how it happens. So the caution here to take is try and look out for side effects compared to conditions and other drugs that might be given to you to compare with. All right. What else can we remember about sildenafil? Just before anyone at all comes in, please note that we have other drugs apart from sildenafil, okay, which is also a phosphodiesterase inhibitor. Most of them end in that dinafil or something like fil, okay. I can't mention some here, but I've seen one before that ends in that way. So sometimes, even on the Nclex, if you don't know much about a drug which is being spoken about, the prefix and the suffixes can help you. If, let's say, you've not heard of captopril before, if, let's say, you've not heard of captopril before, and you've heard of enalapril, you can at least try and deduce a meaning into it that they might all fall under the same class, okay, of ACE inhibitors. So that is what I'm talking about. Any other thing to add to sildenafil? Okay. If there is nothing more to add, then I think we can also look at the next one here. If you have any questions, you can ask. So let's talk about chronic cirrhosis LINAC.
Hello.
Okay. Yes, sister.
Hello. Please, the side effect, the H/A, what is that?
Which one?
The
Ah,
Viagra.
okay, so you get okay, I didn't even talk about them. We have facial flashing, we have headache. Okay, this one is headache. Sorry, it has been short. This one is headache. So you have facial flashing, you have dyspepsia. So most of the side effects or the adverse effects mimics that of hypotension. Okay. No, when you have hypotension, you're likely to get all these things. So good. There is even one information here we even didn't talk about. When you take it and you have erection for more than 4 hours, it means it's an issue. You have to call your healthcare provider or your medical doctor, whoever is your head. Okay. So that is it. Please, do you understand it now?
Yes, please. Thank you.
You are welcome. Any other question? Okay. So let's talk about chronic cirrhosis linear in short. Okay. In short. So we are all aware of cirrhosis. I mean, it comes from the word liver cirrhosis. Okay. But with this one attached, what we want to mean is that with this type of chronic cirrhosis, it's mainly caused by alcoholism. So when you see chronic cirrhosis or cirrhosis with this word, LINAC, it means the primary cause is from excessive intake of alcohol. Okay. And you are going to have all those signs and symptoms of liver cirrhosis that everybody should get. Okay. So that is what happens. You know the function of functions of the liver. When the liver function is impaired, you know what is capable of happening to the body, starting from clotting factors and lots of other things you can talk about. Okay. You're going to have jaundice. You're going to have skin issues. Okay. You're going to have skin issues. And at worst, when you have um you have waste buildup in the liver cannot metabolize most of the things we take in, whether food or drugs, and they end up becoming waste substances in the body. I want to mention a word, but I want to ask before. Who knows what I want to ask concerning waste products that builds up in the body because of inability of the liver to break them down? It has a way of affecting the brain.
Yeah,
What's the name of that condition?
it will crosses the blood-brain barrier and cause let's say altered mental status to the patient.
Yes, that is true. We have a name for it. Who remembers?
Hepatic encephalopathy.
Good, good. Hepatic encephalopathy. Okay. So what I was trying to say is that you might get a condition. I don't know if you heard that part earlier because I was trying to talk plenty and I didn't know I was already taking off. So what I want to say is that at times you can get some case study questions. Some case study question. They might begin with, let's say, liver cirrhosis, and at the end of the day, they might end up with hepatic encephalopathy. And we know, of course, they are related. I was also mentioning the fact that they might begin with DVT, and at the end of the day, lead you into pulmonary embolism. And we know how well they are related. If the patient has no history of extensive surgeries, okay, yes, so just take note. And we all know that they are well linked in that manner. So let us take note. And should we get them on the Nclex? Some conditions can even be linked, like 3 steps ahead or 3 different conditions all linked together because, depending on what is happening, their pathophysiology and all of that, it is possible that way. So let us be ready for all of those things should we meet them on our Nclex, okay? All right. Now, the Next one, I want us to run very fast with these ones because the main thing to talk about is the questions. And the main thing I want us to go through is the questions and how we can deal with them, not the content reviewing right now. We are just revising anyway. So with cystic fibrosis, please, unless someone has something also to tell us about. So, this one is also cirrhosis. So think about all your liver cirrhosis conditions. Okay, signs and symptoms, how it's been diagnosed and all of that. They are all in here because at the end of the day, it is still liver cirrhosis. So just a reminder. Now with the fourth one here, cystic fibrosis. We have, should I say cystic fibrosis affects two main systems, okay? Cystic fibrosis affects two main systems. We have other systems that it can also affect. We'll look at that. Okay, so, but let us take note that it affects two main systems. I'll talk about the I'll talk about the digestive system part first. Okay. So when you hear of cystic fibrosis, just think about thick secretions. Okay. As soon as you hear about cystic fibrosis, think about thick secretions. Also note that it is a disease that is it has a genetic something to do with it. Okay. So it's a genetic disorder. Let me say that people are born with it. You can't get it from anywhere unless you are born with it. So just take note of it. So thinking of thick secretions in cystic fibrosis, to talk about the digestive system part first. To talk about the digestive system part first, this is what happens. We all know that when food is ingested, it gets into the stomach and it finally pours into the small intestines. Let me draw something here to represent something. Let's say you have your small intestines going this way, okay? Then it continues that way. We have a duct. The duct is linked to the liver, then also the pancreas, okay? So let's say this is your pancreas. Okay, so we have pancreatic juice being secreted by the pancreas and flows into the small intestine. Remember, this is your GIT. Let's say this one goes up, it's connected to your stomach, then to your mouth, your alimentary canal. So food after your stomach gets into the small intestines. If it reaches here, in the duodenum, especially, that's where you have this thing happening. The pancreas secretes pancreatic juice. Apart from the pancreas secreting the pancreatic juice, what is its endocrine function? Just one.
Secret
Endocrine
insulin.
Decrease insulin.
Insulin.
Yes, insulin production, good. So its exocrine function is to secrete the pancreatic juice, which contains the lipase, amylase, pancreatic lipase, pancreatic amylase, and trypsin, right? To break down carbohydrates, fat and oil, and proteins, right? These three things. You have the bile too. So this one is connected to the bile that, you have the bile coming here. So what I want to talk, I'm not talking about the digestive system in details, but I just need this portion. All right. We have thick mucus forming plugs, especially around these ducts. Okay. Actually, when you eat anything, the end product of, or let's say the final form of digestion occurs in the duodenum. The mouth will have some form of digestion to make, especially starting carbohydrate digestion in there. There is some small form of fat hydrolysis too over there. Okay. Proteins also starting from the stomach, digestion of protein and all of that. But they are all not completed. When it gets to the small intestine, that is where everything is being completed. You have the bile, which should pour onto food to emulsify fats. Okay. You have this pancreatic juice and the rest to also come and act on the food to finally break it down into their end products, ready to be absorbed inside the ileum. Okay. And in people with cystic fibrosis, you have thick mucus plug blocking this sphincter of Oddi, okay, at this point, hepatopancreatic duct somewhere here. And these secretions, which are supposed to pour on the food, will not pour on food. So fats and all of that, which is supposed to be broken down, are not well digested. Okay, they are not well digested, and they come out like that. That's why people with cystic fibrosis, they have diet issues. Okay, they have weight loss and all of that. The nature of their stool too is a fatty stool. Okay, because the bile is supposed to emulsify the fats, break them down, and the good parts will be absorbed by the body in the ileum. But in this case, the bile is not pouring on the food to emulsify the fat and all of that. So everything will come out. That's why for them, with regards to the diet issues, you have to increase carbohydrates, increase almost everything. Okay. You either increase for energy or calories, you have to increase. Fats, you have to increase, or they take them in moderation. Then proteins too. Okay. So let us take notes. So that is what happens when it comes to the digestive system parts, which is affected in people with cystic fibrosis. So what do we let them do to help with these digestion issues? We have something we call pancrealipase. Okay, pancrealipase. We are not doing extensive review on this. I'm just mentioning all that I can remember right now on these things. If you have any information, you can add. Pancrealipase, we let them sprinkle on food. Okay, I think sometimes they swallow whole with food. And look at the name of the drug, pancrealipase. Okay, I don't know whether the spelling is even correct. Lipase, okay, something like this. So that will help break down the food. The function that is supposed to be achieved here, the drug will help break down the food so that the body can absorb them. All right. So that is what is happening in people with cystic fibrosis, the digestive part. Now let us talk about the um, the respiratory part. With the respiratory part, remember I said whenever you hear of cystic fibrosis, think about thick secretions. So you have these people also producing thick secretions in a way that they are not able to even clear these secretions. In their right proportion. Okay. So they get these things accumulated. They get thick secretions accumulated within their, let me say, tracheobronchial tree. Okay, their trachea, bronchus, and all of that inside the lower respiratory tracts. Okay, and that makes it, remember that, the alveoli, let me try and see if I can also draw something here with respect to the respiratory system. So let's say this is the bronchial tree. Please, I'm just using this as a sketch, okay, just to represent A. Why don't the kidney? Just like a kidney. Let's just take it as lungs, okay? Okay. So there's the left lung, there's the right lung, okay. You have alveoli. The alveoli is the basic unit of the respiratory system, small, small. Whenever air comes in, within the alveoli sacs is where gaseous exchange occurs. The lungs will remove, or the alveoli, they will remove the blood that comes to the lungs, and they remove the CO2 part of it, carbon dioxide, and exchange it with the oxygen coming into the lungs. So they will put oxygen into the blood and remove carbon dioxide out of the blood and give it to the respiratory system to bring out. Now, in this condition, you have thick secretions, okay, within the tracheobronchial tree. So thick secretions are all in here. So thick secretions are all in here. Please, I hope you can hear me, right? Okay.
Yes, please.
Thick secretions are all in here. And for that matter, the exchange of gases that is supposed to be done by the alveoli, it's not been achieved. Okay, so you see continuous buildup of CO2. And with time, they will develop something we call a kind of chest. We call this barrel chest. Their chest will look something like hyperinflated. It is the same thing that happens in conditions like COPD. They also have this barrel chest, hyperinflated chest. Okay, so it's similar in terms of the physiology. It's very similar. It all goes down to this gaseous exchange and carbon dioxide accumulation. All right, so they end up even getting atelectasis, which is lung collapse. All right, and when you have these perfusion issues, you know what can happen. The pleural discoloration, like cyanosis, you can get periodic cyanosis. You can get this digital clubbing or clubbing of the fingers. Is the same thing we are talking about. And remember, they tend to get lots of respiratory conditions, okay, or let me say respiratory infections. They get it a lot. And the reason is very simple. When you have mucus staying at one place for a very long time, they become a nice or optimal medium for microorganisms to thrive. So you see microorganisms thriving around those areas. So they easily get pneumonia and other respiratory conditions easily. Okay. So that is basically what is happening in the respiratory system of people with cystic fibrosis. That's basically, you can talk about some other things in details, but that is basically what is happening. With regards, you see, I told you the main systems are two. That's respiratory and the digestive system. And we've talked about them right now. With regards to the reproductive system, remember we are still saying thick secretions. So in males especially, in males, they tend to get, or let me say, we tend to get thick semen, okay, in a way that sperms cannot swim freely. So people with cystic fibrosis are likely to get infertile, okay, in this case, because of these thick secretions. And I think the last system we can talk about is with the integumentary system. Okay, integumentary system. That's why we even have something we call sweat test. Some even call it sweat chloride test. Okay, remember, I think we have it here. So when you do your sweat test, it's one thing that we do to confirm whether you have cystic fibrosis or not. And it should be anything around 40, like 40 or less. If you have it above 60, if you have it above 60, when you do the sweat chloride test or sweat test and you have it above 60, then it could mean you have cystic fibrosis. All right. So those are the other two. So in some books, you see cystic fibrosis happening to 4 main systems. Some will tell you 2 main systems, but we've talked about all the 4 and why they are like that and how everything happens in there with people with cystic fibrosis. I think that is okay with that. Then with pheochromocytoma, this one I want someone to tell me something about it. What do you remember about pheochromocytoma? Then we
Excuse-
look at our questions.
Hello, Gia.
What did you just say?
I have a question, sir.
Oh, okay.
So kindly elaborate more on the sweat test. How is it done? How do they collect the sample?
How is the sweat test done? Is that your question? Hello. The person is not here. Can you hear me?
Yes, sir, I am here. I was asking how is the sweat test done? How do they collect the sample?
Oh, okay. So who can help us? I think they use a filter paper or gauze. Okay. They use a filter paper. I don't actually know the I mean how it's done from head to toe, but I know they use either a gauze or something like filter paper to collect the sample. And I don't know which machine that mix up or that finalize the sample, but I mean with the sweat collection, they use either filter paper or gauze.
Okay,
Please, are
sir.
you okay? Or if
Yeah.
anyone has something to adapt, the person can adapt. Or we can as well read more about how it's being carried out. All right. So
Please, I have-
let me just
Hello.
yeah.
Please, how does is it? I don't even know how to ask it. So, because of the thick secretions that is being produced under this condition, that is why there is enough. Patients have to be in like a lot of fluids have to be given to the patient. Or I'm confused, please, because I know sodium is in relation with cystic fibrosis. Or
I don't
you.
understand your question well because I've not mentioned flues here anyway. But if you have anything, maybe maybe, or if someone understands what she's trying to ask. Please, let us help our sister. If someone understands what she's trying to say. I try to say that people with cystic fibrosis, we try to resuscitate them with fleas. Is that what you're trying to say?
No, please. I think I saw a question
Mm-hmm.
in with sodium. I've forgotten, but I don't know. Maybe I'll have to go back and read again.
So what was the question saying?
Please, I'll go back and read again.
Uh,
But,
okay. Or if there's anyone here who knows something small about what our sister wants to talk about, you can bring it out. All right. If not, then let's talk about pheochromocytoma. Okay. So with pheochromocytoma, there is there's a famous thing we always say that at least know what everybody knows before going to the Nclex. Take note that pheochromocytoma is one of the things that everybody knows before going to the Nclex. Okay. Yes. So take note of it very well. When we talk about pheochromocytoma, what happens is that you have a tumor, okay? A tumor that um, forms or happens to form within your adrenal glands, okay? And you know your adrenal glands produces lots of catecholamines, right? Uh, Adrenalines and the rest, okay? Things that can raise up your blood pressures, heart rate, and all of that, okay? So when you have a tumor inside your adrenal glands, you can have hyper secretions of all these catecholamines we're talking about. So people with pheochromocytoma can tend to have all of these hyper, I mean, they can have high forms of blood pressures, heart rates, and all of that. Let me say all of those conditions that catecholamines can bring about. Okay. So what we can say about them is that try, especially as part of our nursing management, the least thing you can do, especially if you want to do abdominal assessments or something, please do not palpate their abdomen. Okay. The reason for that is when you palpate their abdomen, you are likely to cause a fast release of these catecholamines we're talking about. Blood pressures will go very, 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 very high. Already you have it going high. You have blood pressure, saturates and everything going high. We're going to make it worse this time. Okay. And we all don't want blood pressures to be abnormally high. All right. They tend to get headache, sweat. Some people even call these three conditions hypertension, headache, and the last one, I don't know whether it's heart rate or excessive sweating. They call it pheochromocytoma triad, something like that. We are all trying to brainstorm here. Okay. So just take notes of all these things we're talking about. Yes. So everything goes high, hyperglycemia, everything, they all go up. All right. What else can we remember about pheochromocytoma apart from the signs and symptoms we talked about? All right. I think we should end it here. Then go to our question. We've revised about 5 conditions, though we didn't go details. Okay. We didn't go into details, but at least we've been able to go through most of them. So let us try and now answer some of these questions, and let's see. For those who were able to join the last session, the last week's session, this is our first question. Okay. So our first question on sildenafil. Now, we've now got into our main aim for this lecture: how to deal with questions strategically and get it correct. So here is it. Sildenafil, which is Viagra, is prescribed to treat a client with erectile dysfunction. A nurse reviews the client's medical record and would question the prescription if which of the following is noted in the client's history. Remember, we've revised a bit. You know what sildenafil can do. Now, they're asking you. So most of the times, I always say that questions like this, they come in 2 forms, okay? The first part normally is a preamble. It's an information that they want you to consider to help you answer the main question, which is mostly asked at last. So you see, this is just a preamble, the first part of it. Now, the second part of it continues to say that a nurse reviews the client's record. Remember, we've given you an information here already. So we now review the client's records and what prescription would the nurse question if noted in the client's history. Who can help us with that? If you can help us, then you raise up your hand. Let us call you. Who can help? I want to hear voices. Who can help? Okay, now Meli.
Hi, good evening. Okay,
Good evening.
so the answer is number 3, use of nitroglycerin. We all know nitroglycerin is a vasodilator, and so the person cannot use that in addition to the Viagra.
Okay. You've done very well. Mr. Vivian, do you have similar thing to say?
Yes, so that was what I was about to say. Thank you.
Of course. So should you get questions like this on the Nclex? Do you think it's difficult? Nclex questions are just like this, and most people living come to report to us that our questions are even more difficult than what is on the Nclex. All right. So we train you the harder or the hard way, so that when you go and you meet things, you can be able to sail through. The questions over there are not too difficult. They are just simple questions. But if you don't know your content, just tricky. And remember what I told you before, if you don't know your content, for even every wrong answer, it has been well calculated for. And if you are failing, you will fail with confidence. You will fail with confidence because you will find your every answer in there and you think you are through. And that is where it's going to cost you. So let us take notes. That is the rationale in brief. Well done with that one. Let us look at another question quickly. So we will deal with the select or data apply questions very well, very soon, but let us try this one. We've talked about celiac disease. Let us see how we can answer this question. During an outpatient client visit, A female patient reports feeling abdominal bloating or pain and diarrhea when eating foods that contain wheat or rye. Remember the brown diet we talked about. The patient states her mother was diagnosed with celiac disease 5 years ago. What other symptoms will you assess the patient for that can be present in celiac disease? So you select all that apply. So this one, let us do it together because of the list of the options. Now, the first one, unexplained weight loss. Are we supposed to see this in there? If yes,
Yes.
interested in why or how does it happen? We explained it. Why do they have the weight loss? Because anything that they take containing any of the brown diets, okay, or gluten, they tend to have inflammation of the bowel, okay, especially the small bowel. And when you have inflammation of the small bowel, the bowel will not function properly as it's supposed to be. So any food that gets in there, it runs through the anus, then it goes away. So you can't absorb food as you should. And when that compounds, you will get, or you surely get what weight loss. So that's one way of it. Okay, the next one. Jelly likes to. Jelly likes to. So this is the point where things get tricky. Yes or no? Hello? Did you get this question? Which one will you choose?
Yes, so
You choose yes, eh? Okay,
I'll choose yes.
okay. After we will check it out to see. But let me put asterisk here, just in case. What about mouth ulcers? Can we get mouth ulcers? What is another name, or do we have? I want you to think this way. Okay, because we are doing it together, let me say this. Do we have a name for a condition that ends up, one getting this mouth ulcers?
Yeah, anemia.
Anemia,
Yes.
mouth ulcers, eh?
Yes.
Good.
And SLE.
And we have another one too.
SLE.
SLT can get mouth ulcers. Okay.
Yeah.
I'm even looking at nutrients related diseases like uh, nutrient malabsorption related diseases. So anemia, as you said, I was even looking at scurvy. Do you remember scurvy? When you have lack of vitamin C, yeah, vitamin C is scurvy. Do you remember that? All right. So are we choosing option C or not?
We are choosing it.
Okay, thank you. Menstrual irregularities, yes or no?
Yes.
Yes.
You remember we said it, right? Pain at McBurney's point. Is it part?
No.
So why is this not part?
McBurney's point is appendicitis.
Appendicitis is good. Ribbon likes to.
No.
Mm-hmm.
No.
No,
Okay.
no, no.
All right.
Hirschsprung's disease or something.
Go again. All right. The next one, inability to tolerate dairy products.
No, that is lactose
No,
intolerant.
lactose intolerance. This is brown.
Okay. Then the last one, enamel changes.
No. That one is with those with the eating disorders. I think
Okay.
it's, yeah.
So it's a no or yes. Which one are we picking?
For me, it's a no.
Yeah, me, me say yes.
Okay. Yes, yes and no, eh? Okay.
Because
Let,
they have mouth ulcers, definitely. Only change.
let us look at our answers before I even clean. So you see our answers. Unexplained weight loss. We have mouth ulcers, menstrual irregularities, inability to tolerate dairy products, and enamel changes. Remember questions like this on the Nclex. It's going to be +1 -1 for you. All right. So we had few ones. Let me talk about why jelly-like stool is not part. Jelly-like stools are found in which conditions? Which condition can you find jelly-like stool?
Intussusception.
Intussusception. Good. Remember we said steatorrhea, okay, over here in this. Steatorrhea is different from what? Is different from jelly-like stool. So jelly-like stool, you find it in conditions like intussusception. Take note of it very well. Then ribbon-like stool, you find it in conditions like what?
Hirschsprung's.
Hirschsprung's. Good. Okay, Hirschsprung's disease. Let us take note very, 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 very well. All right. Now our next one. We'll finish with this one right now, then we will begin with the select or that apply things. So a patient with late stage cirrhosis develops portal hypertension. Which of the following options below are complications that can develop from this condition? When you have portal hypertension, if you remember your portal circulation very well, what do you think will happen? We can try. Okay, this one, let's do it together because it's multiple answers. Do we think the first one is parts? Would the person have increased albumin levels?
No,
Is
decrease.
it even linked? Is it even
No,
linked? Okay, like in that manner, no. What about ascites?
Yes.
Ascites can happen, that is true. So those swellings, anything that causes fluid shifts into interstitial spaces. You know, ascites is a form of third space shifting. Splenomegaly, it's a swelling. We have accumulation of unwanted fluid in an organ or at a space. So what do we do to see to it? Should we choose it? I
Yes.
guess yes, yes. Then option D, fluid volume deficit or deficient. Would the person get fluid volume deficiency?
No, please.
I'm thinking of overload rather.
Okay. Okay. What about esophageal varices?
Yes.
Yes, the person can get it. So look at this question, for instance. If you don't know much about portal hypertension, are you sure you are likely able to going to solve these questions correct? Of course,
No,
no.
sir.
So that is why we always say in everything, your content is the key. There is no straight strategy that cut across
Hold on
everything.
here.
Okay,
Oh, we'll check your lawyer.
so let us take notes. This was just very simple. Move on to the next one. I think we will finish it very soon. Your patient with cirrhosis has severe splenomegaly. As the nurse, you will make it priority to monitor the patient for signs and symptoms of which one? The patient has cirrhosis and now has severe splenomegaly. So which of the following factors will you monitor? Since it is a letter that apply, let us also do it this one together. Thrombocytopenia, will you monitor for signs of thrombocytopenia?
Yes.
For this one, I'm going to take rationale. Why? Why do you think it's important in a person with cirrhosis?
Bleeding.
Okay, okay. The person will tend to bleed. Okay, you let us take it like that. Okay, yes. So when you have liver cirrhosis, factors that helps to create clotting factors, okay, or platelets, I mean, they wouldn't be produced, and patients will have bleeding issues. What about vision changes? Should it be part? Liver cirrhosis, can it affect vision change?
I don't think so, please.
So the reason for having this lecture is for you to have this similar spirit,
Yes.
even on your main exam. Okay, during your main exam. For select all that apply questions, options that you are not entirely sure, please leave it alone. It is better. Okay. Options that you are, you are entirely not sure, leave it alone. But those you are sure, you can choose. Remember the last time I told you it's better to get 0 than to get -1. 0 is better than -1. After all, if you don't owe anyone and you are there, you are a bit safer than someone who owes. All right. So we are not sure about vision changes, so we will leave it out. What about the increased prothrombin time? Then INR. Will we get this?
No,
How do you understand increased prothrombin time?
it will clot fast.
Okay. Okay. I sure it means it will clot fast.
So you ask how I understand it. So how I understand is what I'm saying.
Okay. Okay. All right, I understand you. Okay, so
The
if
person
they,
maybe
when
may
you have
have a high
increased
risk.
prothrombin time, it means it's a delayed. It's the same as delayed prothrombin time. Okay.
So the person is prone to bleeding.
The person is
Yes,
going to begin rather.
exactly. Okay,
Oh,
when you
okay.
have
Okay.
so
Thank
so again,
you.
if let's say the normal time for you to clot, let's say prothrombin time is let's say 12. I'm just using this as an example. And if your blood is clotting at let's say 18 or 20 thereabout, it means this is an increased PT. It means you are delaying to clot. Okay, that's what it means. So would that happen in someone with cirrhosis?
Yes.
Yeah. Yes.
Okay. What about like leukopenia? Leukopenia, would that also happen? Of course. Leukopenia too is there. Okay. Leukopenia too is there. All right. If you have any question, you can ask. Let me clear.
Oh, hello.
Yes, sister.
Can you come again with the explanation of the PT and INR?
PT is prothrombin time, then INR, international normalized ratio. They are all used to measure how well you clot. And we have another one, PTT, right? Prothrombin. This one is prothrombin time. Then
APT.
the PTT is partial thromboplastin time or something like that. Yes.
So this is for
Uh,
warfarin.
come again.
Warfarin. Oh.
Yes, this one is for warfarin. The PT and INR is for warfarin, but the APTT is for heparin. Okay.
I know all this, but I have a little confusion with you said it means how fast it clots or how like it
Okay.
confuses
So
me all the or yeah.
the increased PT and the rest. Is that part which confuses you?
Yeah. Sometimes
Okay.
I think that this is the how fast. Sometimes I think it's how it delay and the other one
Okay.
APTT. Like so when
Okay.
I send
So
them a question.
okay. So if let's say the normal is up to 12, okay, just an example. If let's say the normal is up to 12, it means for a normal person with a normal, I mean, platelets counts and not actually platelet count, like a normal PT. Let me use the word PT. I want to be more emphatic on these ones. You should, if let's say it's about 12, the normal is 12, okay. But if let's say you are not clotting within the normal and it takes time. Okay, so let me say at normal, let's say your PT should clot at 12 seconds. Let me use this as an example. Okay, let's say 12 seconds. And if you are having increased PT, it means, we're talking about time here, recruitment time. So if you have increased PT, it means your time to clot is increasing. And if your time to clot is increasing, it means you are delaying to clot. Do you understand that principle? So anyone who has increased PT or INR, it means the person is delaying to clot. Actually, it's supposed to clot lesser, okay, in lesser time than that range that maybe you might be reaching. Please, have I been able to help you or you still don't understand?
Hey, thank you.
So you can, if you want to know the differences too, you can kindly remind me right after class. You can send me a message. I'll give you if only you want it, the differences between this one, and the APTT. Okay.
Okay, thank you.
Some tabular
Thank
differences
you.
that will strike out the exact
We
differences. All right.
Sir, please, can
Any
you
other question?
explain the
We
D of
wanted to.
the leukopenia?
Saima,
Yes, sister.
Saima, please can you put it on the page so that all of us can benefit?
Yes, yes. So I'll drop it on the masterclass page. But I need someone to remind me, otherwise, otherwise it will pass somewhere. So right after class, someone should send me a message and I'll put the table on the page. Comparing these three things, PTINR and this APTT. All right. Someone was asking leukopenia, right?
Yes, sir. Kindly explain
So
why.
leukopenia simply means low white blood cell counts, right? Uh-huh. You want to know why? Who can help us? Why do we have leukopenia in someone with cirrhosis?
I think the person will be very find it difficult to fight infections.
The person will be having a difficult
To
to
fight
fight
infection.
infection. Okay, okay, okay,
Yes, please.
okay. All right. Please, you understand it?
Yes.
Mhm. So thank you for coming in this time. We've done well. All right.
Saima, somebody
Yes,
asked
sister.
in the chat that it's going to be high or low.
Come again. Which chat?
Somebody asked a question in the
Uh-huh.
chat.
In the chat. Okay, okay. That's
Yes, said then the leukopenia is going to be high. I think
leukopenia simply means low white blood cell count.
maybe
The
the
word
person means high white blood cells. You know the normal is I think is it 5,000 to 10,000. So the person is
mhm.
thinking when it's a seed, like let's say 11,000 going, that one too is infection. All right. So I think that's where the confusion is. I don't know if you will elaborate for us to understand
Okay.
it.
So when you have, I think so this is how I think it is. But let us all find out. Okay. I think when you have liver cirrhosis, the same way clotting factors are destroyed, white blood cells too are destroyed, not necessarily because of infection. Let me repeat myself again. We should still find out, okay? But how I understand the leukopenia in someone with liver cirrhosis, the same way that you have thrombocytopenia, okay? You have that in liver cirrhosis. So the same way that, and you see, there's even splenomegaly here. So I think in this condition, you have the spleen and the liver all destroying blood cells. And platelets, when platelets are destroyed, you get thrombocytopenia. When white blood cells are destroyed, you get them to be low. Because if there is presence of infection, you are likely to get higher white blood cell counts rather. Okay, I think there was a hand up here. Abibatu.
I
Yes.
wanted to add something about the leukopenia. You see,
Okay.
the liver has Kupffer cells
Kappa cells,
that
yes.
works with yes
Yes.
with phagocytosis when there is an infection, and then when there is
Good.
a problem with the liver, it's the strength of the Kupffer cells or whatever becomes weak. So the person easily gets any infection and cannot fight infections when there is infection. That's my
Okay.
little understanding.
Okay. So someone was asking, if you can't fight infections, then it means your white blood cell count should rather be elevated, right? As we see in people with normal infections. Isn't it that's the case? So I am thinking the leukopenia is because of self-destructive mechanisms that goes on when someone has liver cirrhosis. Okay. the liver with, you see, this one too, the question even mentioned the splenomegaly. So blood cells are being destroyed. And this person too can get anemia. The anemia too could also come from the destruction of red blood cells as well, which is also possible happening here. So you have all the three types of blood cells being broken down. So you're going to have issues with clotting, you're going to have issues with your HB, you're going to have issues with your white blood cell count, which is, to go down. So that's how I understand it. So that's how come you can get the leukopenia. Infection itself should send your white blood cell count high. Please, do you understand what I'm trying to say?
Taima, can I say something in addition?
All right.
So I think the liver and then the spleen also, they are also responsible in the filtering of blood, right?
Okay. Yeah.
Eliminating the, yes. So in the event that there's an enlargement of the spleen and then the liver too, their responsibility of filtering will decrease. Thereby, the the blood circulation or accumulation in that event will rather increase since they are not filtering it. So when the WBC is high, that means infection has taken place, whereby infection is also as a result of splenomegaly. If I don't know if I'm right or wrong, that's my
Yeah,
thing.
okay. Okay, thank you. And there's also another factor. Thank you very much. There's also another factor. You see, the liver produces erythropoietin, which helps in blood formation, right? So I think this part can even explain it well. And I think this part is the main cause. All that you were saying could be additional cause, but I think this one too can even be the main cause. If erythropoietin, after all, we know that erythropoietin, the liver helps to produce them. Okay. If the let's say erythropoietin is disturbed, okay. If erythropoietin production is disturbed, what do you think will happen? Blood cells won't be formed, okay. Blood cells won't be formed, and or if they will be formed, it will be in their lower concentration, and that could also lead to these things you are talking about. Please, am I making sense?
Please, is it the same as the NIDA or is it NIDA or NIDA?
Your voice is low. Is it the same as what?
NIDA, NADIR. I don't know if I'm correct with the spelling. Or
And what do you say? And what?
NADIR.
Okay. But this is just it's like an English word though. Like lowest concentration of something, right? That's how I understand it.
Yes,
The
please.
lowest concentration, So you're linking this nadir towards which one?
To the leukopenia.
To the look, so something like that. Yes, you have the least production of it. Yes, so we can just link it to it in that way. All right. Think we've said enough. I might end this one very soon so that we look at the select order to apply part. Richardson, you can ask your question.
Yeah, before we move to the next question, my understanding on the increased INR and PT, I think it contradicts with you. So I want to be very clear before you move on.
Okay.
With my understanding of the PT and INR, I think that when there is an increased PT and then INR, it means that the patient is at risk for bleeding a lot. But I think when you were explaining, you said when you have an increased PT and the INR, it means that you tend to clot. So I want to be clear before maybe you move on. Thank you.
Okay, I think you didn't understand me well. I was saying exactly what you said, but I said it in a different way. So I was saying when you have an increased PT and INR, it means you are not clotting faster or normal as you should, or your clotting is delayed. That's when you have increased. So when I use the 12, when I was using the 12 seconds, so I was saying that if let's say your normal PT should be 12, and let's say you are clotting at 20 seconds, it means your clotting is delayed. So when you have increased PT, it means your clotting is delayed, and that means that you are bleeding a lot. So it's the same as you understand what you just said. Mr.
All right.
Richardson, do you understand me now?
Yes, I do. Thank you very much.
You're welcome. Yeah. Please, any other question? Okay, so let's pick this one quickly. You're providing an in-service training to a new nurse graduate about esophageal varices in patients with cirrhosis. I think we should even, let us skip this one and do, I want us to do the select or that apply right now. Let me check something and see. Because of our time factor. Let us pick maybe one last question. The things are plenty. Let me see. Yes, let's make this single one. Let's let others apply. We will do it. We'll do them when we get to those ones. The nurse is teaching the mother. Please, let's take this one to be the last one. Then we can close for this chapter. The nurse is teaching the mother of a child with cystic fibrosis how to do postural drainage. Remember, with the with the respiratory aspects, we said they have thick secretions. Though we didn't mention this when we were talking about it during the review, right? But they will need posterior drainage to help loosen some of the secretions on the chest, in the chest. Okay. So we are saying the nurse should tell the mother to do what among these options? Which one do we think is correct? This will be our last question, so that we can do something else. Oh, no one wants to answer. Did I answer myself?
Please, what is clapped hands?
What
I'll
is
choose change positions every 20 minutes.
change position every 20 minutes?
I'll choose A.
Are you being realistic enough? Can you can you do this yourself?
I'll do A.
You do
Say my please.
I'll choose D.
okay. I think D is better. Okay, when you are doing posterior drainage,
Yes.
I think D is better. You see, if the person can sit, you allow the person to sit, then you use the cupped hand to percuss it's like a slap, okay? You slap the back and the chest, but with a cupped hands. Okay. So in that order. We have lots of questions that we can do. They are all good, but I want us to start with to start and even finish. Sorry, to start and even finish with the select or that apply things. All right. So I think we should end it here. Let us end it here and look at the other aspect of it. All right. Thank you.